Welcome to the Make a Mental Note podcast, where mental health professionals share information and perspectives that illuminate, educate, and is worthy of a mental note. And now your host, Chris Quarto.
Hi, everyone. Welcome again to this episode of the Make a Mental Note podcast, the very last one in the series. And I'll explain more at the very end of this episode. My mental health tip for today has to do with dealing with feelings of insecurity in relationships. You probably know people who feel insecure in their relationships, and maybe you're one of them. Stuff starts creeping into their minds like, I wonder if he really loves me, or I don't like the way she looked at that guy. And of course, the only thing this does is reinforce the strength of the fear that underlies these thoughts. Well, here are 4 things you can do if you or someone you know falls into this trap. First of all, nip negative thinking in the bud. You know, it'd be nice if every relationship was perfect, but that's not the case. Something can and probably will happen that places a strain on the relationship, and for some people it's easy to jump to the conclusion that this spells big trouble. Acknowledging and accepting that relationship conflict is normal and happens from time to time and doesn't necessarily spell trouble is key. Number 2, remember that every relationship is unique. It's possible that your previous relationship was a bad one, and so you start looking for your current partner to start doing the same things. And in some cases that might happen, by the way. There might be some similarities between the new person and the other person, and so it's easy to start making generalizations. This is the way all guys are. They're only looking for one thing. Doing some comparing and contrasting of people that you become involved with might help you get a better perspective on things. So in other words, ask yourself, how is the person similar to people I've been involved with in the past? And how are they different? Also, talking to friends or family members about their experiences with relationships might help you see how relationships are unique. Number 3, understand that there's no such thing as a perfect relationship or a perfect partner. Some people try to pick a partner like they do fruit in a grocery store, trying to pick the perfect guy or girl without blemishes, but there is no such thing. They're just imperfect people with different types of blemishes and flaws. And the trick is to find the imperfect person whose imperfections don't trigger strong feelings of insecurity. And number 4, be careful not to fall into the habit of mind reading and fortune telling. You know, oftentimes people who are insecure in their relationships think they know what their partner's thinking, which is probably something along the lines of, he doesn't like the way I look. He thinks that other girls look better than I do. In other cases, insecure people make predictions about the future that drive them crazy, like, he'll probably leave me by the end of the month and find someone else. If you do something like this, then it's important not to automatically accept these thoughts as gospel truth and to question yourself. Like, why am I thinking this way? I don't have any proof that he's thinking that way about me. What's the flip side of the coin? Well, I mean, what are some good things that he could be thinking about me? You know, self-reflection is the key to using any of these strategies successfully. Give some thought to your tendencies, your styles of relating to partners, and assumptions and conclusions you make about them in order to make these strategies work for you. And that's my mental health tip for the day. Okay, without further ado, here is my interview with Russ Federman. Hi, everyone. This is Chris Quarto. Welcome again to the Make a Mental Note podcast. I am joined today by Russ Federman, who is a licensed psychologist in Charlottesville, Virginia. He writes a blog for Psychology Today called Bipolar U, and also has written a book called Facing Bipolar Disorder, The Young Adult's Guide to Dealing with Bipolar Disorder. And Russ, welcome to the podcast.
Thanks, Chris. I'm glad to be here.
Well, why don't you share a little bit with the audience about what you do when you're not writing blogs or books?
Yeah, well, my practice is pretty much of a full-time practice, and so I spend much of my work week simply seeing patients and managing the complexities of a large practice.
All right.
And my wife and I are now empty nesters, and so we have a degree of freedom to enjoy our spare time. And I like to garden and fly fish, and I'm doing my best to make the most out of my 60s. So,
isn't that great? Yeah, my wife and I just entered the empty nest as well, and I'll tell you, it's really nice. It's going back to those early years prior to kids, and just being able to do the things and to have the freedom. I think that's the nice thing about it.
Right, and you asked me about my practice, and probably about 2/3 of the people I see are individuals diagnosed with bipolar disorder, and I understand that's somewhat unusual for psychologists. It's not typically what we see in psychological practice, but it just kind of has evolved that way for me. I don't think that 15 or 20 years ago I ever set out to have that be the case, but it indeed is now.
Okay.
And that kind of has become my area of expertise.
Well, tell the audience a little bit about how you got into the field of psychology, and then we'll talk a little bit more about your practice with bipolar disorder clients.
Sure. When I graduated with my undergraduate in psychology, I really had little idea of what I wanted to do professionally, and so I worked for a number of years at human service type jobs, working in the social services, and after 3 years post BA, I got a master's in psychology.
Mm-hmm.
And then I got a master's level position working as a psychologist at a large county mental health center. That was back in the days when county mental health centers were well funded.
Yes.
And did that for 4 years, and then it became clear to me that really was my path or my calling, and went on to do a PhD at that point, and I completed my PhD in 1982.
Mm-hmm.
So I also think that becoming a psychologist probably for me started when I was about 1.5 years old, in the sense that when I was a young child, I had polio, and I was paralyzed bilaterally with both legs. And in the years following that, what evolved was a very, very intensive relationship with my mother, who just kind of devoted herself to my rehab.
All right.
But retrospectively, when I think about my mother, I'm aware that she really had a very narcissistic personality style. And so I think one of the things I learned early on in my development was that if my needs were going to be maximally met by her, I needed to become attuned to her needs and her feelings. And so I think the fact that interpersonal attunement, or being able to empathize with the other, probably is something I learned a long, long time ago.
Okay.
Now, did I know that when I was 20? No, I didn't. But in my late 20s and into my 30s, as I did my own kind of psychoanalysis, all that stuff became very apparent to me, and it was clear that my profession wasn't just that it was an interesting profession, but that indeed it had some deep roots within my own development. I actually think that that's not that uncommon for folks who pursue clinical psychology.
Yeah, I was just about to say that we've had many guests on the podcast who have shared similar things, not necessarily what you just said, not that specific, but how early life experiences play a major role, not only in personality development, but in their decision to enter the helping profession. And it sounds like that's what happened with you.
Sure. I think that as psychotherapists, we're attracted, we're drawn to this field because typically we know something about the experience of emotional, psychological pain and struggle. I think when you see folks who really have kind of gilded lives where they don't face painful, difficult struggles, and where things go rather smoothly. I don't often see them attracted to psychology. And I'm not saying they're not out there.
Right.
But on the whole, I think those individuals who go towards the human services field do so because at some level they've had to do their own personal journey. Through difficulties and challenges.
Yes.
You know?
Well, say a little bit more about how you got into working with bipolar disorder clients. What's that all about?
Sure. Well, in 1991, I was hired to be the director of mental health services at East Carolina University, and what they were doing at that time is they were creating a separate mental health services separate from the student counseling center.
Okay.
And the mission of the mental health services at that time was to see the students with more acute and complex psychopathology. So the students who needed more psychiatrically oriented treatment approaches.
Right.
And mental health services were situated at student health, and we had psychiatrists on staff. And so it was, rather than it being a full service counseling center serving the needs of the broad student body, it really was something that was serving the needs of those with significant psychiatric difficulties. So I did that for 9 years, and as you might imagine, during my 9 years in that setting, I saw more bipolar students than I would have otherwise seen if I had just been a staff psychologist in a large counseling center. Right. So in 2000, I was able to. I was hired as the director of counseling and psychological services at the University of Virginia, and it became clear to my staff that I already had a fair amount of experience with the bipolar students, and as a director, I was not just a full-time administrator. I also maintained my hand in the clinical work.
Okay.
And so staff started referring bipolar students to me.
Okay.
And so little by little, my experience with bipolar students just gradually increased. And there was one of our staff psychiatrists that I was working with, Dr. Andy Thompson, and he and I worked very well together. And we both decided that it probably was time to put a book together about the issues and challenges that young adults faced, in particular, in first coming to terms with the bipolar diagnosis.
Isn't that interesting? So you really never set out to work with these clients specifically?
Absolutely. No, I didn't. And then once the book came out, then I also was offered the blog at Psychology Today, which I've been writing, and as things occur in life, little by little, things gain traction and they grow and they expand, and now here I am as a specialist with bipolar disorder. Though again, 15, 20 years ago, if you had said, "Gee, do you have a strong interest?" I would have said, "Well, it's kind of interesting, but it certainly wasn't. It certainly wasn't my goal or objective at that time."
That's fascinating. Well, for the audience,
what I'd also say to your listeners, especially to those who, let's say, are graduate students or those who are considering this field, is that being knowledgeable and skillful with bipolar patients is an interesting niche in terms of professional identity.
Okay.
There aren't many psychologists who really do that predominantly.
Right.
Like in Charlottesville, certainly there are many other clinicians here who work with bipolar patients from time to time, but that's different than having it be a very focused area of specialization.
Exactly.
And I think what some of your folks will recognize, especially those early in their career, is that there's not a lot of competition yet. In terms of non-MDs who really have this area of specialty. And so if one is able to develop it over the course of one's profession, it really is a very, very strong set of skills and abilities to have in terms of building and developing a practice.
Yeah, that's great to know, because typically You hear, psychiatrists using medication to treat these patients, but you don't really hear as much just about psychologists or other mental health professionals working with these people in more of a psychotherapy or counseling context. It's usually the medication is the big thing that drives this, it seems like. And so this really seems to be a unique area for you in particular. But what I hear you saying is that for others who may want to go into this field.
Right. It is. And what I would also say is that the issues that are so ripe for psychotherapy are really, really important for the individual living with bipolar disorder. This isn't just an illness where if you get the right medication, you're okay. Because even with the right combinations of medication, there's no guarantee that one will have continued stability. In fact, I just rarely see it. Usually I see a fair amount of instability, and even when patients are able to, in concert with their psychiatrist, come up with a combination that works well, that doesn't mean that they don't still struggle with some mood variability.
Yeah.
And so living with mood that you, I would say often, but at least sometimes don't feel in control of, is a very, very difficult and challenging way to live.
Yeah.
Not to mention the issues of stigma in terms of having a psychiatric diagnosis. And so the amount of work that is very, very relevant for psychotherapy as opposed to psychiatric medication management is pretty extensive with the bipolar population.
Yeah.
And I find that those with bipolar, if they can find a therapist who is good at what he or she is doing, psychotherapy is very helpful. I mean, we don't cure bipolar disorder. I'm not going to make someone's bipolar disorder go away.
Right.
But to help them to live with it and manage it with more grace. Right. As opposed to doing a bunch of maladaptive stuff that actually exacerbates their mood instability. That's really the goal of the treatment, to help people both with acceptance of the disorder as well as management of lifestyle that contributes towards a lower incidence of symptoms.
Yeah, and as you were talking about that, I was thinking about how it sounds like it's more of a chronic condition that has to be managed, a lot like maybe how diabetes or a health condition may have to be managed over the course of the lifetime.
Very much. And let me kind of loop back to where we started. And the interesting piece for me, and with regard to the bigger question of why is it I've developed this area of specialty, I do think that through my experience of having lived with a physical disability, I know what it is to live with limitations. I know what it is to have a body that doesn't work the way most people's bodies.
Right.
I know the adolescent issues of anger and denial and resistance and all of that as they pertain to disability. And so I think I've found in my work with bipolar folks that it's something I can connect with fairly easily.
Yes.
The big advantage I have is that the disability doesn't include my mind and my emotions, And so probably what makes bipolar is very unique. What makes it unique is that we can look towards diabetes or we can look towards other conditions, and indeed they're chronic and they need a lot of ongoing management and acceptance, but the conditions don't affect the lenses through which we perceive the world.
Right.
Whereas bipolar does, it happens in our mind, in our brain. And so learning to both accept it and manage it when at the same time you're being profoundly affected by it, it requires beginning to separate out the illness from the self, and that's not easy to do.
Right. Well, Russ, for people who aren't really familiar with bipolar disorder, they may have heard this term, but not really understand what it's all about. So, in more of a layman's terms, can you just kind of give us a description about what it is, and then how people with bipolar disorder might present themselves to you in a psychotherapy session?
Sure. First, I'll start by saying I think bipolar is often misunderstood.
Mm-hmm.
And because when lay people think of bipolar disorder, if they don't know it, like if they don't have a friend or relatives or someone in their world who has bipolar,
Mm-hmm.
all they get are the media portrayals
Right.
of bipolar.
Exactly.
And often those are portrayals of bipolar in its more exaggerated or acute state.
Mm-hmm.
We don't read the stories of people who are functioning well with their illness. We read the stories in the news about the people who have had a meltdown because of their illness.
Yeah.
So when people think about bipolar disorder, they often think, wow, that's really acute. That's really crazy. That's people with bipolar disorder are crazy. And it just is not the case. In fact, Kate Jameson and Guy Goodwin in 2007 wrote a large 2-volume book called Manic-Depressive Illness and Bipolar Disorders, and it's by Frederick Goodwin and Kate Jameson. They devoted a lot to outcome studies of folks with bipolar.
Okay.
And what fascinated me is that they found that in reviewing all of the longitudinal research that had been done to date at the time that they wrote the book, they concluded that about 1/3 of the population either grows out of it. In other words, they somehow become no longer symptomatic.
All right.
And they don't need help. And then about 1/3 of the population lives with a moderate degree of symptoms, but is able to manage their symptoms well through treatment.
All right.
And then 1/3 of the population is more in acute distress and is experiencing repeated hospitalizations on disability and essentially not able to function well.
Okay.
Right? Now, that bottom third, that's controversial because there are a lot of folks who say, well, if indeed you're bipolar, if you're truly bipolar, then you're not going to grow out of it. And so I think what you have is that you have indeed people who are identified as bipolar, but it was a misdiagnosis.
Sure.
And so they get better. But I think there's another factor here having to do with maturity, and that is, imagine someone on the spectrum of mood instability, but their symptoms are mild, meaning the extent to which they experience their depressive symptoms or the extent to which they experience mood elevation. And I'll define that better in a few minutes. But the extent to which they experience elevation is in the relatively mild range. It does not create a lot of functional impairment for them.
All right.
And we're looking at them at age 19 or 20. And if you look at that same person 10 years later, who has a stable job, stable lifestyle, they're getting adequate regular sleep. They're not using psychoactive substances the way they were 20, the way they were when they were 20. When you look at that picture at 30, there's a lot more stability there that helps to mitigate mood instability.
Mm-hmm.
So I think there are some people who you may see them in their late teens or 20s, and they may fit criteria for bipolar disorder, but then you give them another 10 years of maturity and growth and experience, and not so much that their mood variability goes away, but more they become adept and more competent at managing it, such that they're not seeking out treatment, and thus they no longer fit criteria for diagnosis.
Okay.
Right? But if we think of that 1/3, 1/3, 1/3, what it really says is that 2/3 of the bipolar population is very adequately functional.
Yeah.
And they don't necessarily present in ways that people deem to be, crazy or acute or out of control. And so that's one of the reasons I see it's often misconstrued. Now, in terms of what is bipolarity, most people know what depression is. Most people at times experience acute sad feelings, and hopefully that's transient for them. But then there are those where that acute sadness kind of hangs on and it may hold on for several weeks or a month, and that's really where you see what we call depression.
All right.
And again, I think most people get a sense of, okay, so this is what depressed mood is. You feel bad, your energy is down, you have low motivation, you're withdrawn interpersonally. Your esteem is low, your self-esteem is low. You just don't feel very good about life, right?
Right.
Then there's this place in mood called mid-range, where I think most of us kind of live most of the time, where you're not feeling down, you're not feeling up, you're just kind of in the middle, and you're managing life day to day, right?
Right.
Good mood is what we all want. I think it's what all people strive for. It's to have a sense of feeling mildly up, optimistic, happy, pleasure, experiencing pleasure.
Yeah.
And there's nothing pathologic with normal good mood. But if you think of mood as continuing up further, if you think of this broad continuum and imagine that good mood is just at one end and you take the intensity up further, then we enter a realm that we call hypomania.
All right.
And hypo means below, like a hypodermic needle.
Yeah.
So if mania is at the top, hypomania means it's below mania, but it's above good mood. And so what do we see? What do we see with hypomania? We see elevated energy, elevated mood, and this third is key: lessened need for sleep.
Okay.
It really is critical. And think of a battery that is in some ways overcharged, and rather than needing a 7 or 8 hour charge, you can plug it in for 2 or 3 hours, and it's ready to go the next day with the same amount of charge as if it got its normal 7 or 8 hours.
Yeah.
Right?
Yeah.
So in hypomania, you have lessened need for sleep. You have rapid thought, sometimes racing thought, rapid speech. Sometimes cognition can become a bit disorganized because the faster it goes, the harder it is to keep it cohesive. You have people who become a bit more impulsive. So as things speed up, then rather than being able to normally go into the kind of thought process where they utilize judgment and their own ability to self-observe and ask themselves, is this a good thing to do? It's more like the impulse comes up, they want it, they want to do it, and they do it. And they do it because just the intensity level is high, and their ability to put the brakes on is low. Sometimes as mood becomes more elevated, you see grandiosity, so people having perceptions of their own capacities that are really quite exaggerated. So the perception of self is a grandiose, unrealistic perception of self. As mood goes up further, one can even become delusional. So that perceptions of self and perceptions of reality are more affected by internal thoughts and fantasies rather than the external world.
Okay.
And the point at which hypomania becomes strong enough that one is really no longer in control of behavior, that's what we call manic or mania.
I see.
So when someone is manic, they've reached a level of intensity where everything I've described is intense enough that they're no longer in control, right? But much of the time, people with mood elevation are experiencing hypomania as opposed to mania.
Okay.
One clarification I want to make is that this is not simply a matter of happy sad, because most people, when mood begins to elevate into hypomania, and as it goes up the scale, they find it isn't necessarily pleasurable. There's a point at which the intensity creates distress.
I see.
The intensity is, it may be pleasurable for 2 or 3 days, but after 5, 6, 8 days,
Yeah.
Things begin to unravel because the person can no longer manage the intensity well. Most individuals who are not bipolar, their ability to keep mood relatively balanced in the middle is a given. It's just part of how they live in the world. And with the bipolar individual, that's where you see kind of faulty brain neurochemistry, such as the shift from normal mood into depressed mood, or normal mood into elevated mood, can occur apart from external influences. So if I have a few wonderful things happen, I'm going to feel great for a few days, right? And so there's nothing unordinary about my feeling good because good things have happened. But when one is going through life and just out of nowhere mood begins to elevate, and it's not tied to external reasons, then what we're seeing is really more of the brain's inability to regulate neurochemistry, such that neurochemistry maintains normal mid-range mood.
Right.
And so the bipolar individual is often struggling to stay in the middle, to stay out of depression, or even to keep from going up, because usually there are a fair amount of negative consequences when mood begins to elevate.
So, Russ,
so that's kind of an overview of bipolarity.
And that's really helpful, because I don't think a lot of people really understand. I think most people get what you were talking about the depression, but I think the hypomania and the mania, I think that's a little less clear for many people. So that description really helps a lot. And as I was listening to you, I was wondering, when you have these patients in with you talking, what are some of the topics, or what is it that you actually talk to them about in these sessions? I know a lot of them are young adults. So what are some of the topics or themes of these conversations that you have with them in psychotherapy?
Okay, well, let's talk about, let's divide this into issues of psychological acceptance versus issues of symptom management, because they're real different.
Yeah.
The young adult who comes into treatment because he or she has just been diagnosed, right? And maybe even their diagnosis involved a first hospitalization. So you have, let's think of this hypothetical 19-year-old who maybe is in his or her, second year of school, second year of college, and they've had a strong hypomanic or manic episode, and they wind up being hospitalized, and they're diagnosed bipolar, and they're told, usually without a lot of psychotherapy while they're in the hospital, they're told, if indeed this diagnosis is accurate, this is likely going to be a chronic condition, and you're going to need, ongoing psychiatric care.
Right.
Well, for the 19-year-old, that's not the future they had in mind at all.
Yeah.
It's not even close, And usually for the individual with bipolar disorder, they're needing to take a couple, sometimes 2 or 3 different medications to give them adequate balance of mood. And those medications are not without side effects. And so there is the very difficult pill to swallow, so to speak, where you've got young adults who are taking medications that indeed have some side effects, but they can't just say, the hell with this, I don't want to take the medications, because then they're at high risk for a relapse.
Right.
And that is a major dilemma for the 19-year-old. So for the 19-year-old to begin to wrap their head around what what the diagnosis means, what it requires of them, how it will affect their future. Those are huge issues.
Right.
And so that's usually where I begin.
Okay.
And then once the individual has come through an initial period of, how shall I say, I guess coming to terms with the reality of their illness, then you've got to turn your attention to symptom management, and that really means lifestyle management.
Uh-huh.
And here's where this is difficult, because if you live with bipolar disorder, then what is ideal, and actually not just ideal, it's more like what is necessary to assist with mood stability, is that you get stable, regular, consistent sleep.
Uh-huh.
You know, you go to bed at the same time, you wake up at the same time in the morning, you get a good 7, 8, 9 hours, and you do that 7 nights a week. Right? Show me one 19-year-old who does that.
Mm-hmm.
In addition, we find that psychoactive substances, whether we're talking about alcohol use, cannabis, or any of the other drugs that young adults are experimenting with, I'm not one of these who views substances as evil or as bad, but particularly for the bipolar population, they contribute to mood instability. So in addition to having to get good, consistent sleep for the 19-year-old to say to his or her peers, hey guys, I really don't drink, or I don't get high, or no, I can't go out to a bar with you tonight. You know, to decline those options places them at major odds with behavioral norms for much of their peer group.
Oh, sure.
And so they wind up feeling somewhat marginalized and peripheralized and stigmatized, and these are difficult issues for the young adult.
Mm-hmm.
And you're basically helping the young adult to figure out how do I live, how do I follow a stable lifestyle that is conducive to my physical and emotional health while also being a college student. And that's no small set of tasks. You know, those are major challenges.
Yeah, and I was just thinking as you were talking about that, it's quite similar to people who deal with addiction. And they make a decision, okay, I've got to do something about this, whether it's I decrease my use or I stop altogether. But it's the same sort of thing that you were talking about, Russ, is that I have my friends who are saying, hey, what's up, dude? You're not using anymore? Let's go out. Let's go out and party. And it has to be so difficult for them to make that kind of a change, that kind of a transition.
Well, you know, and I think it is still a lot more acceptable for a young adult to say to a peer, you know, I've been drinking too much lately, and I'm finding it's not good for me, and so I'm really trying to stay away from it, versus saying, dude, I got bipolar disorder. I can't. Yeah. You know, there's still a lot more stigma that comes with conveying one's diagnosis to peers, and so people often feel fairly secretive. In fact, kind of connecting this with my practice, for the last 6 years that I was at UVA, and for the past 2 years or 3 years since I've been in private practice, so probably for about 9 years now, I've been leading bipolar student support groups. Okay. So when I was at UVA, we had them, and now I also have them in my practice, and I find it is so important for the young adult with bipolar disorder to be able to meet with others who are facing similar challenges, so they can be open about it, and they can receive support and assistance and advice from others who are going through similar things. It's when I look at the group and when I do the individual therapy, sometimes I have a hard time imagining these folks. I'm imagining helping them if indeed they weren't in a group. Yeah. This group has so much of a beneficial effect with this population.
Well, Russ, many years ago, I had worked in a community mental health center, and I didn't have a lot of clients who had bipolar disorder, but what I found was that at some point in time, many of these clients or patients would say, you know what, I don't think I need to take my medication anymore. I'm feeling great, and why do I need to take this anymore? When in fact, maybe it was because they were taking the medication that they were feeling better, or they didn't like the way that the medication made them feel, and so they didn't want anything to do with it. So what do you do in those cases, Russ, where you have patients who are saying, I don't want to take the medication, or I just don't need it anymore?
Well, I think working with young adults who have bipolar disorder requires an enormous degree of patience. And I'm not talking about PATIENTS either.
Yeah.
So
Yes.
the therapist has to be very patient with the folks that he or she is working with. Because the conditions you just described are inevitable. If you have a young adult who is doing well, let's say they've been without symptoms for 5, 6, 8 months, given the developmental issues at that point in life, aren't they going to want to see themselves as not having the disorder,
right,
as opposed to doing well because they're taking the medication?
Yes.
So the inclination to want to do a trial without medication and just see how they do is strong. Or, as you point out, they may be feeling mildly hypomanic. They're feeling good. And partly through that perception of optimism and everything is wonderful, they say, I don't need this medication. I can do fine without it.
Yeah.
Because they're not being able to realistically assess what's going on. And so they impulsively stop medicine. And in either of those cases, whether it's an impulsive thing that comes as a function of their own hypomanic elevation, or it's more of a reasoned, thought-through decision that they don't think they really have the illness they want to do a trial without, in either, I think you just have to be there to, well, one, you advise them of the risks they're taking. And the person who is hypomanic is going to be less able to hear that because they're not going to be able to slow down and alter their decision process very easily. But even the young adult who just wants to be without their meds because they want to see how they do well, you advise them of the risks and you let them know what relapse would potentially look like, and you'd be there to help them up after they fall. In other words, if they stop their medication and if they relapse, then that's an important part of their learning.
Yes.
And I find that with the young adult population, the experience of learning from their errors and learning from their impulsive choices or their poor judgment, that's an early part of back up. It's an important part of the early journey through the illness.
Okay.
I'm thinking of one patient that comes to mind who he was a very outstanding athlete and just had all kinds of success, but was actually kicked off of 2 different varsity teams because of substance use.
All right.
And then finally had a first manic episode and was hospitalized and continued to use substances and be in denial. And I believe then had a second or a third. And I think probably by the third time this guy was hospitalized, it was like, God, I don't ever want to have to go through that again.
Yes.
You know?
Yep.
But I don't think he would have gotten there without the pain and the trauma of the early hospitalizations. It was just a gradual process of learning through negative consequence.
Yeah.
And sometimes we can do everything we can to help. We can give someone all the right information. We can be caring and concerned and supportive and all that. the bottom line is they're still going to make their own decisions.
Yeah.
And as a therapist, you can't be with them 24/7.
Right.
And so when people make bad decisions and they have bad outcomes, then they learn from that, and that's part of learning to live with bipolar disorder.
Yeah, and in some cases they hit the proverbial rock bottom, I guess.
Yeah, right. And so something else you mentioned that I wanted to address, and that is, it's not uncommon that medications that folks take for bipolar disorder do come with some side effects.
Uh-huh.
And those side effects, I mean, they vary from person to person. I've seen some who are able to take mood stabilizers or even low-dose antipsychotics and experience very few or even no side effects.
Right.
But that's not the case for most.
Yeah.
Most people, if they're on a mood stabilizer, if they're having to take anti-anxiety meds, or even if they're having to take an antipsychotic at night to help them with sleep, usually the combinations of those medications bring about a degree of cognitive blunting. And so the mind just doesn't feel as sharp as it does without the medication. And again, imagine you're a young college student where you absolutely need your mind to be as sharp as it can be. Then having to accept some of the limitations that come with the medications or some of the side effects that come with the medications is a very difficult thing to adjust to. Yeah.
Well, Russ, I often talk to my guest about what their recipe for success is in helping a client move from point A when they first come into psychotherapy to point B when they're done. But I wonder if it's a little bit different for bipolar patients. It's not necessarily coming in with a problem, but it's not the typical type of psychotherapy that you might do with somebody who perhaps has just depression or maybe anxiety or has some relationship issues. This is a little bit different because it's the chronic management of a condition like we were talking about before. So say a little bit more about how you know, I guess, when a person, I guess, is at that point B when they don't need to come in to see you anymore, and kind of what happens in between that point A and point B.
Yeah. Do we have another couple of hours? No. Well, let me back up a little bit and say that we as therapists, we also face the reality that many who come in with bipolar disorder, which is a neurobiologic condition, right?
Yep.
They may also have some psychological or personality-based problems too.
Okay.
So this isn't exclusive, as in if you have bipolar disorder, then you don't have things that you struggle with in the realm of your psyche. Indeed, you may, and then that makes for a more complex picture.
Sure.
Now, our role as a clinician is to do our best to try to separate those in our own minds, so we understand, okay, what are the symptoms of the illness, but then what are the manifestations of this particular person's maladaptive style?
Right.
Like, I mean, we all have things we struggle with, right? And individuals with bipolar, they have aspects of their personality that they struggle with. And so often keeping that in mind as a therapist and say, okay, I can't cure their bipolar disorder, but if I can help them to be healthier within their own psyche and within their own lives, then they're going to be better able to manage the symptoms that come with their disorder. Yeah. So there are times where treating someone with bipolar disorder looks exactly like psychotherapy with someone who doesn't have bipolar disorder because of what you might be talking about during the psychotherapy session.
And that's really good to know, because I think that a lot of people will probably make the mistake that I did in just kind of looking at this disorder as something, once again, that's just treated with medication primarily, and perhaps overlooking some of the issues issues that these folks are dealing with.
Right. This is not a dichotomous, either you have a biological condition or you have a psychological condition. You indeed at times have both.
Yeah.
And so you need to be addressing both. Now, in terms of the chronic aspects of the condition, I actually think of 5 different areas that are important in terms of, well, not start to finish, but in terms of getting someone to a healthy place of living well with their bipolar. And the first is, as I said earlier, their acceptance of the diagnosis, as well as their acceptance of some of the functional limitations that come with the diagnosis.
All right.
Second is a strong commitment to physical health. So if I can get someone exercising 3 or 4 times a week, and if they're physically fit, they're going to be, that's going to help them tremendously, particularly with regard to depression.
Uh-huh.
Right? You take any depressed person and get them exercising regularly, and most people are going to feel better.
Mm-hmm.
And since depression is a strong part of bipolar disorder, then physical well-being, physical fitness is really important.
Yes.
The third is simply remaining compliant with medication treatment. So being willing to work in an ongoing relationship with a psychiatrist who you have a good collaborative connection with, where both of you strive to find the best combination of medicines with the least or the lowest incidence of side effects.
Uh-huh.
Okay, that's an important goal. The fourth is refraining from use of psychoactive substances. And I already addressed that. And the fifth is having kind of a well-established professional treatment team. So we're talking about your psychiatrist, your psychotherapist, and it depends on where you are geographically. Like, let's say you're an adult and you're at a university that's 6 hours away from your home.
Uh-huh.
You might also have a treatment team that you have in place during the summer months when they're home for 3 or 4 months.
Right.
And so you might need to have professionals in place in different locations. And a second part of a well-established treatment team is having a personally fulfilling personal support group or personal support system. I mean, bipolar disorder it's a hard road to hoe.
Yeah.
And I find that those who do well are people who are better connected interpersonally. And so having folks you can reach out to and share with and feel connected to, I think we just do better in this world when we have healthy interpersonal connections.
So, Russ...
whether we're talking about bipolar disorder or whether we're talking about just general living, I think that truth holds. And I find it particularly to be applicable with folks who have a bipolar disorder as well.
Well, Russ, so how do you gauge when a client is in no longer need of your services, or at least your services for a while? I mean, how do you gauge that?
I think that's usually something that we come to collaboratively.
Uh-huh.
I mean, I usually begin, if I begin with someone and they've just come out of the hospital,
uh-huh.
I may see them twice a week for a couple of months,
right,
just to really have a strong support network or support system in place. And then I'll back that off to once a week, and then I'll back that off to every other week.
All right.
What I do with a fair amount of college students who I work with in the support groups I discuss is I may see them 1 week in the support group and then on the alternate week in individual. So you can kind of have a nice combination
Sure.
of every other week individual and support group. And then indeed, if we think of someone who's no longer in the stresses of early adulthood, but maybe they're 40, 45, and you've seen them for a few years and you've really kind of helped them stabilize, and they may say, I'm doing okay now. I don't think I need to see you, at least not regularly. And I say, well, yeah, I agree. Of course you don't. And you know where I am, and give me a call when you need to come back in. So,
right.
There's some people who I might see once a month. There's some people who just might kind of contact me intermittently as the need arises
Mm-hmm.
because of some of the instability that they may be going through. But I don't in any way presume that if you're bipolar, you have to be in therapy forever.
Right.
You really don't. I think it's very, very helpful at the early stages that you're first learning to deal with the illness. And then once you kind of get your feet under you and you're doing well with it, then I think having a therapist in place on an intermittent, as-needed basis is really fine, as long as you feel committed to reaching out to him or her when you need help.
Yeah, so it's an open door policy, what I hear you saying. I mean, once they go through this initially, that if they need to come back, that your door is open, and they know that.
Right, and if we just stay with this notion of bipolar as a chronic condition, you can assume that at times they may need help, and that's okay. It doesn't mean they failed. It just means they're living with their bipolar disorder.
Yeah. Well, if you think of all the work that you've done with these patients over the years, Russ, and if you had to think, what's the main challenge in working with this type of person, what would you say that is?
Acceptance. Acceptance of a particular set of vulnerabilities that they cannot overcome through will or intention.
Mm-hmm.
And so what I'm also saying is acceptance of a degree of helplessness.
Uh-huh.
And I don't mean total helplessness, because everything I've been talking about, in the last 10 minutes has to do with how does someone with bipolar live well.
Right.
How do they do it? How do they do it right?
Right.
And that takes a lot of skill and commitment. But I think I'm saying that even with the best treatment in the world, even with the best treatment and strong commitment, people are still going to experience mood instability.
Uh-huh.
That's just the nature of the beast. That's the illness, right? I think living with a deep acceptance of that,
mm-hmm.
and not somehow living with a sense of chronic victimization,
right.
like, oh my God, life sucks because I have bipolar disorder.
Mm-hmm.
Yes, one might have bipolar disorder, but that doesn't mean that even when faced with difficult times, that you still can't reach for that in life which feels meaningful and fulfilling.
Mm-hmm. Yeah, and I keep making these parallels between the bipolar disorder and addiction, because it's a similar process in having to acknowledge or accept the fact that I've lost control over something. In the case of bipolar disorder, it's certain behaviors or whatever it is. In the case of addiction, it's losing control over their use of a substance or whatnot. And it seems like there's education, that you need to educate the client about, this is what's going on, this is what you're looking at, and this is how you're going to have to manage this condition for perhaps a long time.
Correct.
Yeah. Well, Russ, this last part of the interview, I talk about this as, I refer to it as make a mental note. And it's something that you feel is important for the audience to make a mental note of in terms of improving their mental health or their relationships. It could be for people who have bipolar disorder, or it just could be a suggestion for people in general. Is there anything that comes to mind, just general tips or suggestions that you could provide along those lines?
Yeah. And this has more to do with caution.
All right.
And that is, bipolar disorder often starts as a unipolar depressive disorder.
All right.
Okay. So, the late teen or someone in their early to mid 20s may have a few bouts of depression,
mm-hmm.
and they think, well, all right, I'm depressed. I need help. I need to go see someone. They do, and if they're not carefully or thoroughly depressed, if they're not carefully or thoroughly assessed,
uh-huh.
they may be prescribed an antidepressant. And sometimes what we see is for bipolar disorder that has not fully emerged yet. In other words, it's only shown the depressive side of its bipolarity.
Right.
Then the antidepressant can precipitate the onset of the illness.
Ah.
And so what I need folks to be cautious about is that if you're experiencing depressive symptoms, you need to look very closely at family history.
Okay.
And, you know, and this isn't just, is there anyone else in the family that has bipolar disorder? Because sometimes there are folks with, let's say, mild to moderate cases of bipolar disorder who just have never seen a mental health professional, and so the diagnosis is not established, you know.
Mm-hmm.
But for the individuals to say, do I have any first-degree relatives or even second-degree relatives that just seem to have a lot of mood instability?
Yeah.
Maybe they're angry a lot, or maybe they seem to be sometimes depressed and sometimes they're excited, and, you know, they may not have the diagnosis, but are there patterns observable anywhere in the family that might be indicative of an underlying bipolar disorder? Because that really puts someone at higher risk for their own potential emerging disorder, and if they're treated incorrectly in the early stages, it might kind of bring on an illness which, if it had been treated differently, would be less acute, or perhaps would not even arrive on the scene.
Right. That's okay. That's good stuff. Go ahead. Do you have anything
and
else
that's
you want to
something
add?
that we don't often, we just don't often hear that talked about that much, and I think the general public needs to be mindful of that.
Yeah, I think that's great advice. And
Mm-hmm.
well, Russ, if somebody wants to get a hold of you, maybe a potential patient who would like to schedule an appointment to see you, and also how would they get a hold of you? But also, how could people get your book, Facing Bipolar?
Sure. Well, you just put Facing Bipolar into a search engine, and you'll find it.
Okay.
You know, and it's sold through New Harbinger, and yet you can certainly get it probably less expensive through Amazon.
All right.
Although, if you purchase it through my website, which is www.russfederman.com, then the publishing house gives a 15% discount on it.
Ah. All right.
So there are numerous ways of getting the book. My blog is on Psychology Today. It's titled Bipolar U. That's YOU. If people want to reach me, they can get my contact information through my website.
Okay.
Also, what I do from time to time for folks who don't live in or near the Charlottesville area, let's say someone lives within travel distance, but they're not close, and yet they either want an in-depth initial consultation because they think they may be bipolar, or they just want a second opinion. They want to see someone else. I do sometimes arrange for 2 to 3 hour in-depth assessments. I typically do them on Saturday mornings. I don't easily fit them into my week because I'm usually booked with patients, but someone doesn't live close, and yet they might want to see me for an assessment of that nature. They'd be welcome to contact me, and we could talk about it.
Okay. And we'll make sure and put all of this information about your website and how to access the book on with the show notes so people can get that information easily.
Mm-hmm.
Well, Russ, thanks so much for joining us today. This is great information. I think I've learned a lot just by listening to this, but I'm sure the audience has as well. And I thank you for taking all the time here today to share your expertise with us.
Well, good. I really appreciate it, Chris. Take care.
Thanks. Okay, I appreciate Russ coming on the show today to talk about bipolar disorder. And here's my mental notes takeaway. Bipolar disorder, it's a chronic condition, and people experience extremes of mood, whether it's feeling down in the dumps and depressed on the one hand, or elated, excited, manic on the other hand. And, although it's a condition, it's usually treated with medication. It's important to remember that these people also experience relationship problems and other problems in life that are best addressed with counseling. Now, here's my question for you. Russ talked about 5 areas to help get bipolar disorder patients to a healthy place. Do you remember what those areas were? Well, acceptance of the diagnosis and functional limitations that come with it. That was the first one. And then a strong commitment to physical health, maybe exercising. Third was remaining compliant with medication treatment. 4 is refraining from use of psychoactive substances. And then 5 is having a well-established treatment team. So psychiatrist, psychotherapist, and a support system. And Russ also mentioned that patients that are better connected interpersonally have better treatment outcomes. Well, as I mentioned in my intro today, this is the last Make a Mental Note episode, sad to say. As much as I enjoy interviewing mental health professionals, it's really difficult to get people to participate. I've sent out so many invitations, and for some reason or another, people can't participate or they don't respond to me. So if I had a producer that could take over this part of my responsibilities, it wouldn't be a problem to continue interviewing people, but I'm a one-man show, so I'm going to have to bring this podcast series to a close. I've really enjoyed doing these interviews and hope you've benefited from listening to them. If you like the show notes for today's podcast episode, then as usual, please visit my website, chrisquarto.com. And thanks as always for listening, and have a great rest of the day.